right, we're going to get started now. If you could take your seats. Good evening. My name is Kristen Page Nye, and I'm here on behalf of the American Cancer Society and its advocacy affiliate, the American Cancer Society Cancer Action Network. And we are proud to co-sponsor this event with the Montana Medical Association. Welcome to a community conversation on pain management and opioids and in our community. And I think this is going to be a really, really good conversation by a very diverse cross-section of stakeholders in pain management and then also the public safety around opioids. So I just also wanted to let you guys know that this whole conference has been taped by the Missoula Community Access Television, and thank you for doing that. Thanks. They will be playing this probably in about a month or so in different segments, the whole conference, so if you weren't able to be here during the day, those will be available through the Community Access TV, and they are internet friendly, so we will be posting on the Pain Initiative site the links to those and letting folks know through our Pain Initiative listserv when those will be available. So if you're not on our listserv, make sure to see the registration table and we'll get you on that listserv.
Good evening, my name is Jean Branscombe and I am the CEO of the Montana Medical Association, and we are delighted to be a co-sponsor of tonight's event as well. On behalf of Montana physicians, we are extraordinarily delighted to be part of a conversation that allows all individuals that need to tell their story the chance to be able to share their story and be part of conversations on how we can move forward in Montana to make sure that folks have access to care and the care that they need, while also addressing serious issues in our state in regards to opiate abuse. With that, I do have the pleasure tonight also of introducing Dr. Marc Mentel. If you've been here throughout the day, you know and probably can share with me how wonderful Dr. Mentel is in regards to his passion for this particular topic. He is certainly a physician champion in this particular arena. When he's not hosting a conference like you've been at today, he also is seeing patients and working with physicians in training at the family medicine residency here in Montana. He's a faculty of the osteopathic curriculum at that program. And again, as the physician champion on this topic, he also serves at the Montana Medical Association as a chair of a committee we have there that has cross professions working on this particular topic. He's chair of the MMA committee called To End Opiate Abuse in the state of Montana, but also to make sure that patients have access to the care they need. If you look at the program, he has a quote, "Pain is inevitable, suffering is optional," and this quote certainly demonstrates his belief that all conversations need to focus around our patients and patient care. And we thank him for that, again, passion. Now, I know that he's very passionate about this topic, and I also know Dr. Mentel is very passionate about fishing. But a couple of things you may not know about him that I happened to Google on the internet before I got up here is that his favorite book, these aren't too bad, is the Lord of Rings trilogy. And his favorite movie is Forrest Gump. So in appreciation of Forrest, life is like a box of chocolates. You never know what you're going to get. Well, I assure you tonight that with our panel and with Dr. Mentel being the moderator, that we are in store for some delightfully cream-filled chocolates. There's no jellies up here. So with that, Dr. Mentel, and thank you for attending.
Thanks, Jean. I gotta be careful when you give introductions now. So once again, I thank everyone for being here for the community conversation on managing pain and opiates in our community. And before we start, we kind of have everyone in the back of the room and I know how much I hated doing this when I was sitting on that side, but I want to encourage everyone, please come up and fill these front tables, please. So it makes it easier for us to have a better conversation with who's here, and it'll help the panelists. So please come forward, don't be bashful. Otherwise, we're going to move the panel to the back of the room. So,
We'll just go pick a table to sit at.
so I thank you all for moving up. Thank you once again. Before I introduce our speakers, I just want to go over some ground rules. Everyone's story is important, and we want everyone to be heard because we have a short period of time tonight. However, we may have a little more time because we have a smaller audience, so this might be a little more intimate, which might be nice. Originally, we had planned 1 to 2 minutes for you to ask your questions and 2 to 3 minutes for answers. But we'll see how the time goes, and as moderator, I'll make sure if we're having good conversation, good dialogue, I want to keep that going. And then I will redirect as we need to. So if I interrupt you, I don't mean to be rude, but I just want to make sure other people have time to get conversations in and move in that direction. So I apologize ahead of time if I seem rude, and you can take care of me later, but just try to be polite. So please honor everyone else's time here with this. Before we start, I just want to state this is, again, conversation on pain and managing pain and opiates in our community. So it's about what happens when we see a pain patient and we want to help take care of them. We give them a prescription. That's the only way opiates can get out into the community. It's what happens with those after and where they go that creates so much of a problem. And what we want to do is tell the whole story of opiate from the physician point to the patient point to people who've gotten into trouble, from the pharmacist point, as many point of views and how these touch our community as they go through. Right now, there's been somewhat of a backlash in society of saying rein back on opiates is causing this huge epidemic, which it is. But at the same point in time, as we do that, it's also affecting patients who can benefit from these medicines, who may be showing signs of improving function for them. So we need to find that right balance of making sure we give the patients who need the care they need, but keeping patients who can get harmed from being harmed. So it's trying to find that unique balance, and I'm hoping that we might be able to create some dialogue and discourse on how we get there this evening. So for our first panelist, we have Dr. Jennifer Schneider. She is visiting here from Arizona, Tucson. She's been our keynote speaker all day. I just about have her whooped and tired out. So if anyone is a masseuse out there that can help her later, that would be much appreciated. She's a recognized expert in the management of chronic pain with opiates. She is certified by the board, American Board of Internal Medicine, the American Society of Addiction Medicine, and a diplomat of the American Academy of Pain Management. She's a fellow of the American College of Physicians and is the author of numerous papers in professional journals, in addition to pain management fields as with the book that she wrote called Living with Chronic Pain. For many years, she practiced internal medicine, in addiction medicine and pain management, and has had extensive experience in educating healthcare providers who get into trouble with prescribing and helping them remediate on how to do it appropriately without harming the patient or society. Before medical school, Dr. Schneider earned her PhD from the University of Michigan in molecular genetics. You can find out more about Dr. Schneider on her website, and she's got to be pretty important if she has a website, so I don't have one. Apparently you can pull me up on Google, though. So. Next panelist, we have Kerry Haney. It says Paul Brand, but she just recently changed her name. No, just teasing. Kerry is filling in for Paul Brand, who's not here this evening. But Kerry is a pharmacist. She works at, she's a pharmacist here at the University of Montana. She teaches in the pharmacy school. She also does double duty over at the Family Medicine Residency of Western Montana, where she helps teach the residents the importance of what a pharmacist can help them do in their practice. It's an interdisciplinary team-building exercise where we are starting to learn and teach physicians to work together collaboratively with other professions so we can build a team that helps take care of patients. So we appreciate Dr. Haney here. Next to Dr. Haney, we have Brandy Tyree. She's a prevention specialist who works for the Missoula Forum for Children and Youth. She coordinates 2 coalitions, Missoula Underage Substance Abuse Prevention in the Missoula Prescription Drug Task Force. What she doesn't want you to know is her acronym after her name is PRINCESS.
Nice one. See if I keep secrets with you anymore.
And lastly, we have Tootie Welker. I had a chance to meet Tootie a couple months ago. I was able to do a radio interview with her and Brian Kahn for Home Ground here on Montana Public Radio. It was after that interview, I've been able to forge a friendship with Tootie. Excuse me. I'm so sorry. I'm getting tired, Tootie. Tootie is a longtime sufferer from chronic pain, an advocate for the use of opiates in treating chronic pain. Her experience includes 4 back surgeries resulting in her resignation as executive director of Sanders County Coalition for Families after 15 years. She is currently in the process of earning her currently in the process of earning her second master's degree in sociology, but was unable to complete that degree due to inadequately managed chronic pain. She now spends her time working on solutions that allow doctors to treat pain patients without fear of reprisal, while simultaneously ensuring pain patients have access to appropriate medications will afford them a decent quality of life. And I've had a chance with Tootie. She has a wonderful story to tell, and I'm going to give each panelist a chance to introduce their side of opiates and where they fit into the whole picture. So I'm going to, and each panelist take about 5 to 8 minutes if you can, just to kind of go over exactly what you do and how you fit into the whole medical system of opiates and pain management in our community. So I'll start with Dr. Schneider, if you wouldn't mind.
Sure.
This is not supposed to be
I'm
prepared.
not prepared. I'm not prepared to talk.
Tell a little bit
Okay.
about yourself.
I started out in internal medicine, and then because of a family situation, I ended up learning and getting certified in addiction medicine. And that, as a result of my becoming certified in addiction medicine, I started getting referrals from other doctors in Tucson, where I live, of their patients who the doctors had prescribed opioids for chronic pain. And these doctors were concerned that the patients sometimes were abusing it because they took more than they were being prescribed, when they were actually being prescribed unusually excessively low doses. So I started taking, and then sometimes they were referred to me just because they were doing well on their opioids, but the doses that the doctors are prescribing were high, and they were concerned about regulatory scrutiny, and so they were happy to turn them over to me and put me at risk for the board going after me rather than them. Really, that's how I ended up getting quite a few patients. And so basically, I learned everything about that I know about initially about pain medicine from these patients. In addition, one of my colleagues, another internist who had quite a few pain patients on opioids, left town, moved to Phoenix, and he said, take over my patients. And I said, well, I don't know about treating chronic pain. And he said, well, just read the record and see what I did and all. He was very competent. He was already certified in addiction medicine. So I started that way, and then in the last couple of decades, that basically my practice became all chronic pain. And I learned an awful lot, so I became certified in chronic pain management as well. So what I found was that you really need to put on 2 hats. You have to, as we say, trust but verify. So I have patients who are absolutely benefiting from their opioids. And by benefit, I mean not only that they're getting pain relief, but that their function is improving. Because the real key to deciding whether a patient is doing well on an opioid is, what is their life like? How is their life changed, or let's say improved, as a result of being on these drugs? And so when I see patients who are doing well, who are compliant, who don't have any red flags, which I'm very aware of what the red flags are, and doctors need to be, things like running out early, going to multiple doctors, things like that, losing their prescriptions, or they're always being stolen. I mean, these things can happen one time, but we're talking about a pattern. So the doctors, prescribers who prescribe opioids really need to be tuned into those things and notice them. And so you have to, as I say, believe the patient, but also do these various things that patients may think means that you don't trust them, but really if we don't do those things like getting urine drug screens and putting a limitation on how many days the prescription is for, like a month maximum, we are at risk for getting into problems with the licensing board, and at that point, we're not going to be able to prescribe for anybody. So we have to have these rules. We have to have things like agreements that explain what our expectations are of the patients. But one thing I know is that there are a lot of patients who are reliable, who have been on the same dose for a long time, who are doing well, and they are getting, their well-being is being threatened because there is this one-sided view these days, especially in the media. Practically every day there's some article in newspapers about those, those horrible, dangerous drugs, and the good patients are getting penalized. So I think that we have to really go back to a more balanced perspective on these things.
Thank you, Jennifer. Thanks, Jennifer. Next is Kerry Haney, PharmD.
Hello. I didn't overly prepare either. So I have an interest in this for many different reasons. I've been a pharmacist since 1998, and at that time we were taught in school that opioid pain medications were only for malignant pain and acute pain. And then in the 90s, I saw prescriptions being written a lot for chronic pain reasons, and a lot were very appropriate. But prescribing practices now have led us to where we are today, where I believe we need to find that balance that everyone's talked about, where we really need to still address pain, treat it appropriately, but also we do have a prescription drug problem in Montana, a very significant one. So I'm interested in it from all those different perspectives. I've served on the planning council, and I've shared with the council members that I've also had some chronic pain issues myself. I've had a significant back injury and have had surgery, and I've been on the end of things where I haven't been able to walk and haven't been able to get any relief from pain. And so I understand it from that perspective as well. So I think that's probably my full story. I also am very interested in making sure that the pharmacy students and the medical residents that I work with understand what it's like for patients that they're working with, and really get to know their patients and make sure that they're making good choices and compassionate choices when they work with them.
Next, we have Brandy Tyree, and the one thing I didn't mention about Brandy is I've worked with her on the, you're okay here, I won't go anywhere. I've worked with her on the Missoula Prescription Drug Task Force, and she has a wonderful message about keeping your medication safe that I think is something definitely that everyone needs to hear about, and I'm going to let her do that later this evening if we can. So, Brandy, next.
I rarely need a mic. Hi, thank you so much. I'm just really honored to be a part of this panel. We do come from a perspective of just medication safety, and really tonight I'm representing the Prescription Drug Task Force and all the work that so many of our community members have done. About 6 years ago, I was at, I just started my job here in Missoula, and we were planning a DEA take-back, and there's usually 2 a year, and that had been going through our health department for quite some time. And when I left the meeting, a very big police officer stopped me and introduced himself. I had never known him in my life, and he said, "You're going to do something different than take-backs." I said, "Okay, well, what do you want?" And he said, "We don't have any public education around medication safety, so people don't even know why they would come to a take-back, or the importance of that, or how that can keep them safe and their families safe." So we really started doing the work before we formalized the task force. And what we found when we got together, and Dr. Mentel was one of the first people we talked to, was that we knew that the doctors were talking about this and going to figure out how it needed to work in their profession. Pharmacists were working on this, nurses were working on this, and really who was talking to the community and listening to the community, parents, grandparents, everybody. And so that was the perspective we took, was that that's what we knew. We knew prevention from a community level and would let the professionals each weigh in on that and help us with our messaging. And so through time, listening to all those people, we have been working on an education campaign for about the last 4 years now that's pretty basic: proper use, proper storage, proper disposal. And really, if medications were of all type were utilized in that way, we would have not a significant problem that we have in Montana that leads to deaths, and I think we all kind of know those type of things. But the great thing about the task force is we really just believe in the safety of medication, which everybody I ever talk to feels the same way. So it's just about finding how can we help spread that message, because these people are also busy working with patients. So the task force is designed for everybody to have a voice, and again, I'm really just get to be that voice tonight, because obviously you wouldn't want 30 of us up here. So I'm happy to answer questions about our campaign, but again, the basics is proper use, proper disposal, and proper storage, and we do have handouts at the end, because now in Missoula we have 3 places that you can properly dispose of your medication, and that's really exciting for our community. So thank you for having me.
And next we have Tootie Welker. I got that right that time.
You did. So it's kind of daunting to be, quote, the chronic pain representative for the whole state of Montana. So all I can do is talk about my story and also kind of what I've learned and what I've experienced being a chronic pain person. And sometimes it hasn't been very good, I can honestly say. As Mark said, I've had 4 back surgeries. It was only a couple years ago that I finally had a doctor who suggested that perhaps I had Ehlers-Danlos hypermobility, which no one ever had mentioned to me, even though I've been going to a chiropractor since I was in my 20s. My mom used to say I sat like a pretzel, and they couldn't understand why it didn't hurt, and I thought everybody sat that way. It didn't seem weird. And I could do like the Cirque du Soleil, do a back bend and put my head between my legs and look up. I was great on the gymnastic team, in dance and ballet, but unfortunately no one said, you know what, your back's really not supposed to do that. So my pain went from intermittent to chronic in 2003, and I went through the pain clinic in Missoula and was able to get adequate pain relief. In 2008, it finally had deteriorated to the point I had to have a double fusion. Did okay for a couple years, or a year after the fusion, it kind of took. I weaned off all the drugs, and then as it happens with fusions, although I thought I'd get 10 years between, I got not even 4 years when the next level was slipping, and I had no choice but to get that added to the fusion. And then I ended up having L2 done at 2.5 years. Partly I had that one done a little bit early than was medically necessary, and that was because I couldn't find anybody to treat my pain. So I thought, well, maybe if I get it done early, it'll make it go away. It didn't. So the kind of the things that I just wanted to bring up as someone who's dealt with pain is I did go 6 months with absolutely nothing. I was very clear to Dr. Mentel when we did our interview, to Brian Kahn, that if I didn't have animals, I would have killed myself. To me, quality of life means living. Existing, sorry. So, that's exactly where I was at. Fortunately, through partnership, I was able to finally get pain management, but I wanted to speak to a couple of the things. They keep talking about hyperalgesia. And the pain clinic tried to tell me this, that, well, if you just wean off them, and if you're off them, X amount of time, your pain will be the same level as it was when you're on them. Bullshit. That's my response to that. I went 6 months without anything, and my life existed of getting out of bed, feeding my critters, climbing on the couch with an ice pack. Getting up about 4:30, taking my dogs to the dog park. That was my only socialization every day. And then coming home, and by 7 o'clock, I couldn't be upright anymore because I was in such pain. So back on the couch on an ice pack. Your friends call and say, hey, let's go out. And you're like, no, I'm sorry, I can't do that. And so after a while, they quit calling. So your world just kind of like shrinks to nothing. So the other issues that I want to really address that people deal with, especially chronic pain, and I've heard stories from so many people of going into their doctor for their refill, and the doctor, because of this opioid hysteria, which is what I call it, of saying, sorry, I'm not going to prescribe anymore. They're not weaned. They're not given any kind of compassionate wean. They're not tightened down. They're just like, no, sorry, I'm not going to prescribe. So then you start going to doctor after doctor trying to find someone who would treat you. Well, then you get blamed for doctor shopping. And then you go to different pharmacies, and then you get treated like shit by pharmacists. Sorry about my language, I'm kind of a sailor. And so they start saying things like, oh, well, we're out of hydrocodone, we'll have it next week. So you go to another pharmacist. Well, then you get accused of pharmacy shopping. It's like, but it's not my fault. They're the ones who are doing this. You know, and I think we have to look at it, that chronic pain isn't like, you can't do a cookie cutter approach. Not everybody's pain is the same. The same dosage isn't going to work on every person. Just like in diabetes, we don't give the same amount of insulin. You have to work with the patient. And I guess for the medical providers, the one thing I'd want you to take away is believe people first. And then if you come up with a reason to find out that maybe they're trying to scam the system, but believe them first and then maybe deal with it. You know, I went into an urgent care once in tears because I was in such pain. When I got my notes later, he checked a box that said exaggerated pain behavior. It's like, you know, come on. And I think, and then the last thing is just all the opioid deaths. I think that we're seeing that chronic pain patients who need opioids to have any chronic quality of life, we're being conflated with addicts. And when we're looking at opioid deaths, we're not realizing that if you really look into the data, it's rarely just one opioid. It's benzodiazepines, it's alcohol, it's multiple opioids. It's not, so when you hear the news, and I've written NPR so many times, they finally sent me to the ombudsman because of their stories and how angry I was with the way they would portray and make it sound like it was pain patients who were abusing their opioids and we were the ones who were dying. And it's like, that is not the story, and we need to get the full story out there, and it's much more complex than it's being presented.
Thank you very much, Tootie. And then this is supposed to be a community conversation, so we're opening up questions for the audience just to ask our panelists. And you can direct those questions to which individual panelist you want, or a general question for the panelists, and I can help direct it the way I think it might need to go. So we have microphone to our left and a microphone to our right. And we'll start with any questions out there if anyone has any.
Or just Van.
Yeah.
I was like, wow. I'll start one out, though, and while you guys think of the questions you have. So, Tootie, I mean, your story calls to me, and we need to have the conversations that we're having tonight, so thank you very much for being on the panel. And one of the things that you talked about was to providers, and I would like the providers, Dr. Mentel and Dr. Schneider and any other provider that wants to chime in, is believe the people first and then proceed. How would you respond to that comment in regards to what they're encountering now or feel they're encountering in terms of practice?
First of all, I just want to confirm what you were saying, Tootie, that I think that there is a conflation between pain patients and addicts, and we're being told about people who died, and the assumption seems to be that it was pain patients, whereas in fact it's mostly addicts, because the fact is that pain patients who are taking a stable dose and continue on that dose are very unlikely to suddenly die. There's got to be other factors, and so the opioid-induced deaths of patients who are simply on the stable dose and still taking it are really uncommon. So I think that there is a problem with the media. As far as your question, I had said, you know, trust but verify, and that's really the same thing that you're saying. So I do believe that we have to start out by assuming that a patient is legitimate, but you do the things you need to do. And that means, for example, when you have a new patient that comes in and says they've got chronic pain and that they have been on opioids in the past and they want to continue, you need to get old record. The physician needs to get old records from that patient to confirm that. You need to look it up on every state. Most 49 states have prescription monitoring programs on the website, prescription drug monitoring programs, and that you doctors have access to, and you can look up and see what prescriptions have been of controlled substances like opioids and benzos have been prescribed to these patients in the state. And in fact, half the states now have shared monitoring programs. I mean, it used to be in my state that where there's 4 corners within a short distance that patients would have a doctor in each state, you know, all within a few miles of their home, and they would go and get drugs from each one, and they wouldn't know about it. None of the doctors would know about the others, but now the states have these programs where you can actually get information on the nearby states, which I think is a very good thing. So the point is, you believe the patient, but then you check things out to make sure that everything's legitimate, and you don't just prescribe for them based on the fact that they walked in and said that they needed it. You do a history, you do a physical exam, you question what happened, and so forth. And so you have to do things in a way that deals with both sides of the issue. And I think the problem is that there are some doctors that, and most of them are very well-meaning, but they don't understand that there are people who misuse this. And so anybody that gives a good story, they will prescribe for. And those doctors sometimes get into big trouble with their licensing board for doing that when they get a reputation in the community for being an easy touch, and then lots of people start to come to see them for this. So doctors do have to be concerned about their license and their ability to practice, meaning that it's not because you know, they think you're not honest or they're suspicious people, but it's because we need to protect our ability to continue prescribing for legitimate patients. And that's why we do the urine drug screens and these questions, and we give you only a month at a time and things like that. So it's not been easy for doctors any more than it is for patients. But I think it's really too bad that there are many patients who are benefiting from it in that their life expands and that their function improves. And they are now finding it more difficult. And certainly in my state, what you were saying just now about the multiple pharmacies, you know, one of the things it says in the opioid agreement that we have our patients sign is that they're only going to use one pharmacy. Well, these days what happens is if your local pharmacy doesn't have the drugs, because the large chains are getting the heat about how many of each of these pills they're stocking, so they end up having a smaller supply, and sometimes they can't fill it, and in which case, if the pharmacist is being nice to you, they will get on the phone and call up, you know, a Walgreens or CVS or whatever that may be a mile or two away, and then the pharmacist will say to you, well, I don't have those pills, but just go, you know, next mile to the other pharmacy. And then, of course, on the prescription monitoring program website, it looks like you've gone to 2 different pharmacies, that kind of thing. So these are all serious, these are all realistic problems, as you've been describing. So it is difficult these days for patients, and it's difficult for doctors as well.
Can I just wanted to add one thing to what you were saying about people finding a doctor who you call it a soft touch, and so people start going to him. The other way to look at that is because it's becoming so difficult to find anybody who prescribes. You know, with social media, we're all connected, chronic pain people, and you find out who is willing to, and so of course that's why it looks like this doctor is overprescribing, but in truth it's because you can't find anybody else, and so that's why they end up with a huge caseload of chronic pain. And so I don't know how we find a balance to that.
You're right about that, but when I say soft touch, I'm thinking of, and I do a lot of medical legal consulting, meaning that doctors who are either have heard from the medical licensing board that there's a problem with their prescribing, and then they look for somebody, you know, a lawyer to defend them, and so I get to see their records, or else there's lawsuits and stuff. So I've seen these records, and when I talk about a soft touch, I'm talking about doctors who, for example, the average age in my practice, which was all chronic pain, and many of them, most of them were on opioids, they were like in their 50s, older people. And certainly what you were saying about chronic back pain, when you do have fusion of a couple of joints in the back, then a few years later you're going to have the same problem, exactly what happened to you, upper and lower. And so these are all very, you know, real issues, but these are mostly older people. We had one doctor in my community who had an average age of 30. The word had gotten around. Patients would come to see him. They would only pay cash. They would come in from long distances. That demographic is not that you're one of the few doctors that's willing to prescribe. That demographic suggests there's a real problem. And when you review records of that doctor, they're not doing thorough history and physical. They are willing to prescribe for anybody, and they typically prescribe the same drugs that people like, short-acting drugs, which tend to have a greater effect on the brain than do the long-acting ones. And they usually throw in benzodiazepines like Valium. You know, in other words, they prescribe the same thing for everybody, and they get a reputation that anyone who comes in to see them is going to get prescription. That's what I mean by soft touch, not a doctor. Like, for example, in my community, I had a huge percent of my practice was patients on opioids, but that's because I was one of the few docs that really was doing it in my community, and I knew how to do it with the due diligence. So soft touch, I'm not talking about a doctor that's nice enough to actually prescribe. It's this kind of a situation where you have a reputation that, you know, you're going to see anybody. So
What about the pharmacy perspective? Could you give us your insight in regards to that same statement?
I was listening so intently. Could you repeat the question?
Well, Tootie made a comment about, believe us first
Oh.
and then react. And she talked about some difficulties when we walk into the pharmacies and we have that question and service may be declined. Can you comment in regards to that piece of?
Absolutely. I think I can comment maybe on lots of different perspectives there. I work now in a clinic setting, and so I share Mark and Jennifer's approach with trusting the patient up front, but also verifying. It's very challenging, I think, sometimes to sort out what's really going on. So it's very important to listen to the patient up front, but then we do need things like past medical records, because unfortunately not everyone does tell us the truth. So it is challenging. Doctors go into into practice to take care of people, but sometimes they have folks that don't tell them the truth, and that makes their job really challenging. So absolutely. I don't, actually from my own personal story, I've been accused of pharmacy shopping, which I thought was very interesting. Being a pharmacist, I thought, well, I can kind of get this stuff anywhere I want to. But I was in so much pain that I had to go to the closest pharmacy to me. So if that meant I had to go to the grocery store to get milk, I would bring my prescription to the grocery store because that's as far as I could walk. But if I was going to get hairspray or something at Walgreens, then that might be where I chose to take my prescription. And again, like Tootie said, I wasn't doing anything wrong, but I had physicians accuse me of pharmacy shopping. So I'm also very much an advocate for not creating barriers for people with chronic medical conditions of all sorts. It's hard enough already, so to put up barriers and create barriers for people isn't the right way to go either. So if we have those problems within our systems, we need to fix them. Pharmacists, I think, are in a unique position where we're kind of in a triangle relationship where we have the prescriber, then we have the pharmacist, and we have the patient. And we all kind of assume that we all have these different roles. And so, but there's kind of like, we don't always have all the information, and there's just kind of a triangle that happens. And so we can talk to the patient, give them information. If the patient decides to do something differently than what the doctor talked about, they're out of the loop now too. So it's kind of an interesting dynamic for us, and we have challenges just like everybody else, I think, in this situation. But the bottom line is we all need to work together, I think. Does anyone else have any questions for me?
Kerry,
I'm happy to.
I'm right over here. I was going to ask you a question because it was something that was new to me. I found out as a physician. You might be able to either confirm or straighten me out in the thought process, but if I understand, pharmacies can only order so much per month of an opiate, and so it makes it sometimes hard there are shortages that occur at individual pharmacies. Could you address that a little bit?
I really can. So there's quite a few, as you would probably imagine, there's quite a few regulations around controlled substances for pharmacists, and we are really held to regulations around this. There's federal regulations, state regulations, and now there's also some things that are coming down through some of the large pharmacy chains because of very, very large lawsuits that have happened in other states. So now they have lots of layers within large chain organizations when it comes to stock. We also have to go through a process. We have to fill out forms to order these drugs, and they're a little bit more challenging for us to get compared to other medications. So we have to fill out forms that go to the DEA and do a lot of record keeping around them. So we're a little bit challenged. We could call a pharmacy down the street and ask for a medication for blood pressure, and they could give that to us without this paperwork, but we can't do that with controlled substances, or we're very limited, and it's challenging. So that the legal aspect of it creates some challenges. Also with, sorry. Also with a lot of the robberies that have happened, the pharmacies have also had to be careful about the amounts that they're storing too.
And they have them locked, so.
Thanks, Kerry. I know I'm the moderator, but I was going to speak a little bit to this as well. And the part that touched me about Tootie's story is lack of access for patients to go. Where do they see? And, you know, a lot of them are being referred to pain management specialists, but there aren't enough pain management specialists to deal with the number of pain patients who are out there. Yeah, I think it was either American Pain Association or American Pain Society, and forgive me if I get the acronym wrong. Currently, they estimate there's 100 million people in the U.S. who suffer from a chronic painful condition that's limiting their ability to live a fulfilling life in some way or shape or form. And when you think that there's a little over 300 million people in the United States, that's 1 in 3 patients. You know, there aren't enough chronic pain management specialists to do this. And maybe I'm being Don Quixote and kind of going off in my own left field here, but, you know, I really think it's a purpose of family medicine and primary care to become more, I would incite them or poke them to get them moving to, like, we need as primary care physicians to learn how to manage chronic pain better, learn how to help our patients, because when it comes down to it, all medicine is relationship based, and who better to have that relationship with a patient than their primary care physician, someone they can form a relationship with, talk about what's works for them, and, you know, find out. And I have learned more about chronic pain from my patients than I have ever learned in textbooks. And it's because you talk to them, you listen to them, and you find out exactly what works for them, and you form a trusting relationship. And that's one of the key things to this whole thing. And it's hard for specialists to develop a trusting relationship because they're there for a certain point of care. They're not there to be there for the entire care and coordinate it. So I really make a plea for anyone out there, and for I'm sure everyone who's here is passionate about it, so I don't have to worry about you, and you wouldn't be here if you weren't. But try to provoke or promote your fellow colleagues who are practicing in primary care to, you know, take up the charge a little bit. Come on, many hands make light work. So.
Okay, we have a question over here.
I don't have a question, but I have it's kind of a rhetorical question, I guess, because there's 7 of us that have to leave the state that I know of for treatment, and it'd be really nice to have a doctor that would take us in state. And doctors, I terrify doctors, because not only do I have adhesive arachnoiditis, obliterative adhesive arachnoiditis, but I also have a CYP450 chromosomal defect. And so at one time, my morphine equivalent was 1,600 milligrams a day. And most doctors would look at me and think I was a drug addict at that dose. Currently, I'm at 300 milligrams because of some experimental hormone therapy that I'm on. And it would really be nice to have a doctor in Montana that would be willing to continue that treatment so I don't have to leave the state. It's really hard to fly out of here every 90 days for over 10 years. And it's expensive. And I actually ate out of the garbage can for 2 years to afford my airfare. So if you want to know what the world that we live in, I've had to become a suicide counselor, because when patients get their dose cut by 50% every time they visit their doctor, you know, you have to try to keep them on the planet, don't you? And I'm getting so tired of hearing about another friend of mine, a pain patient that's committed suicide. Way more people are dying from lack of treatment than that are dying of overdoses. And I have a right to say that because my little sister died of an overdose. So I know both sides of the story. I live it. And I think it's sad that there's a Supreme Court ruling that says it's cruel, unusual punishment to fail to treat a murderer in prison. But then a doctor can refuse to treat me and let me live with my pain, which my doctor tells me is worse than metastasized bone cancer. So I just want, like everybody, I want what everybody else has here. I want life. I want to enjoy it with my wife, and I want compassionate medical care. And I want to be able to go to a pharmacy and have them fill my medications and not refuse me. And in the world that we live in today, that's really, really hard. And I think every pain patient, every little legitimate pain patient is suffering from PTSD. Is that how you say it? And so I think that's about it. Other than I'm beginning to think that there's an involuntary passive euthanasia program going because of how many friends I've lost. Because if you don't treat people like me, we're going to kill ourselves. Not that we want to, but we want to live, and it's just wrong to let us die like this without treatment.
If you don't mind, I know Mr. Snook. I hope you don't mind if I mention your name. I'm hoping that you might be able to, if you don't mind sharing, and we don't violate HIPAA, would you mind sharing the regimen you're on? I mean, I'm a family doc, so I have an education base here, and there's more that I need to learn, and I'm trying to. But would you mind telling us what's working for you now?
I'll tell you what I used to be on, first of all. I used to wear 2 100 mgc patches. I got 600 8 milligram Dilaudids and 4 boxes of 1200 mgc lollipops a month. So now I'm on, I take about 300 milligrams of oxycodone a day. So that's quite a drop, I think. I take 2 human growth hormones. I take oxytocin, and that makes me feel good about life and not suicidal. And then I take HCG. I inject 500 units a day. And then some other anti-inflammatories to try to control the inflammation from my disease.
Thank you.
I gave Dr. Lopez, Dr. Forrest's hormone therapy. The doctor I'm seeing now is down at Partnership. They finally accepted me when I went 6 months with no treatment. And I did the Dr. Forrest Tennant, who they're seeing in California, has a website and has a lot of really helpful information. One, there's a pamphlet called Intractable Pain Patient, which, you know, I found very useful, and it talks a lot of things about different diets to help with inflammation, but he also talks about the various hormone levels that need to be checked, that mostly people with chronic pain, your adrenals, a lot of your hormone levels are really depleted because you're dealing with chronic pain all the time, and if you can raise those hormone levels, then you can reduce the amount of pain medicine you need. And I gave Cassandra a copy of that, and we just haven't had a chance to get to that step yet.
Well, I just want to say that, stories like yours are horrifying, your experience. And I am in a battle against this sort of one-sidedness that's going on now. And the reason that I spend so much time educating doctors on how to prescribe and appropriately, including the due diligence that they have to do so that they don't end up becoming a target for patients who are actually going to abuse their drugs, is precisely because it is my effort to try to minimize the kind of situation that happened to you. So that's all I have to say about that.
Thank you. Can I make one more comment? Another reason why these AA patients have to go out of state, why we have to leave Montana, is because the kind of pain doctors that you use are interventional pain doctors, and steroid injections are why we have this disease. So we can't go back to the doctor that gave us this disease and get shots. They won't help us. We're way beyond getting injections or interventions unless our bowel or bladder quits working. That's the only situation they tell us to get any more procedures. And so personally, I feel like a doctor under-medicating me and then using my pain to try to pressure me into procedures it's no different than a male orderly raping a mentally deficient young girl. I mean, when I left Montana, a doctor tried to pressure me into getting 48 epidural injections, a series of 48 injections. And when I told him that while he might be willing to risk what little health I have left, I wasn't willing to let him. He dropped me as a patient with no medication. And so that's just wrong. And I'm not an isolated case. This happens every day in Montana to pain patients who we're like a big money bag, a procedural money bag. And unless we submit, if we refuse to submit, then we're, what do they call the word?
Not non-cooperative.
Yes, well, whatever. Anyway, it's non-compliant. Yeah, we're a non-compliant patient.
I'm a little shocked and horrified that I've not heard one mention of medical cannabis in the treatment of pain. Outside, there's not one booth for a caregiver. The Montana State Legislature recently rolled back medical cannabis. Time and time again, it's proven efficacious in the treatment of chronic pain. I come here as both a neuroscientist and a healthcare provider. My mother was just diagnosed with stage 4 breast cancer that spread to her liver. She just started treatment. Medical cannabis is saving her life. She's on Xylota. It's not supposed to work this well, this fast. Her tumor markers in the past 8 weeks have dropped by 71% and 93% thanks to medical cannabis. Why have you not mentioned medical cannabis? Why are we not mentioning it at all here? It's also been proven time and time again that states with medical cannabis have lower usage rates of opiates. States with medical cannabis have lower overdose rates from painkillers. Why is this not being talked about? Will you also support Initiative 178 come November 8th that legalizes cannabis so people like my mother are able to receive treatment?
I'll field that to the panel here. I have some thoughts, but I want to give everyone else some thoughts on that. So,
I mean, I can say that my provider knows that I use tinctures at night to help me sleep, and she's okay with that, has not made an issue of it. I can't really do it during the day and function very well, but I use it pretty much every night to sleep. And it's been a non-issue for me. In fact, the couple times I've had to do the screen, I've been up front and said, you're going to find THC in it. And it's like, no big deal. And recognize that that's a way to help me sleep. It's better than taking a Xanax, which is what a previous doctor used to give me, was exactly what you were saying, which is what happens with a lot of the ODs, is mixing opioids with Xanax. And so now I use the tincture. I'm planning to stock up before August 31st.
CBD is available in all 50 states.
Right.
Let's talk about it.
Okay.
I have heard about CBD, so if I could give the microphone back to you, sir, because it is out there. And my take on I'm going to play the political neutral ground here. My take on medical cannabis is basically what's stated from the American Academy of Family Practice. And what they state right now is that cannabis needs to be removed from Category 1 status, which means it can't be used, it can't be studied, and it's recommended by my academy to move it to a Category 2 status so we can at least do some randomized controlled studies of this, get some data out there, get some meaningful dosages so we can actually get some quality control out there, knowing what the milligram dosage is, and we can make some comparisons. That's kind of where it needs to go. My other take is that from what I know a little bit about cannabis. I learned more from my patients than anything else. Actually, I think that's where I went to medical school with patients. They taught me most everything. But with cannabis, initially the THC content was much lower than it is now. It's been changed and hybridized over the past several decades to get more and more THC content. But there seems to be some other properties that patients are getting relief from. And these are just anecdotal experiences from my own patient panel. However, I don't have good studies to back that, and I'm stuck in this political quandary right now. So
That's all right. Let's talk at the end. I can do a whole presentation. My father is helping health and treatment awareness, has been talking to some of the world's best cannabis doctors around PhDs. Give him a mic.
yeah.
For anybody that would like information on medical cannabis, I'd be happy to provide all the information you'd love to know and how it can help you. THC is not the only thing that's helpful. There are plenty of blends without THC. You can do high CBD varieties of it or extractions of it that lessen the effects of THC or negate it entirely.
And you had mentioned CBD is available in all 50 states.
Yes.
And I believe that's as an herbal, if I'm recall correct, or is it?
You can get it in a tincture. Best way to currently use it is in a liposome, and it's phenomenal to do so. It enhances drug delivery, as I hope some of you know. Tinctures don't tend to work that well, as ethanol or glycerin that it's soluble in isn't phenomenal for that, but a liposome tends to be incredibly efficacious in delivering the medicine.
And I don't mean to put Dr. Schneider on the spot, but she might know maybe more than I know, but.
No, I don't know more than you know. You know, what the questions I'm asked usually are by physicians who have been disciplined by their medical licensing board, and they ask me what I have to advise them, and I say that there's a couple of issues. One of the issues is that there have not been good studies because it is Schedule I, so I absolutely agree with you, Mark, that the first step has got to be to change it to where it's legal and that people can actually get it for research, and not only that, so that there actually can be some quality control. Right now there's no quality control. People grow it in their backyard or the basement or whatever, and they say there's some percent of CBD or THC, and there often isn't. And so it's very hard to do any sort of high quality studies when you can't even be sure that the drug that you're using actually contains what it's supposed to. And so there's no way you're really going to be able to figure out what you need to. And so I think that we absolutely need to have studies so that we know, because you're saying it's proven to do this and it's proven to do that. But actually, as far as I know, there have not been high quality studies because there is not this quality control. So I don't know, I'm not an expert on that. Arizona, where I live, definitely is one of the many states now that does have medical marijuana laws, but that doesn't mean that there are these good studies. So I think that that's really got to be a first step.
Right. Dr. Sue Sisley was fired last year very, very publicly from the University of Arizona for trying to do a study on medical...
Wasn't able to get the material to do the study, right?
multiple
problem.
reasons, but
Yeah.
backlash from the study, and that the school didn't want to be associated with it, which
That's
is
the
shameful.
problem. Well, but the thing is, everybody's covering their asses, basically, because, it's not legal, and that is a big problem.
Right, yeah. People trying to cover their asses is not the right thing to do when trying to treat patients. It's wrong. I'm sure you all agree with that.
I do agree, but I also know that, as I said, if you make decisions, those of us that actually prescribe opioids and are known in the community for prescribing have to protect our licenses, because otherwise we lose our ability to help the many patients that we are able to help. So, as you said, Mark, there's definitely a political side to all of this.
Can we expect your support on Initiative 178?
I don't live in the state, so I don't have anything with it. I'm sorry.
Arizona, where it is going to be on the ballot in 2016. Can we expect your support there?
You know what? I'm going to have to see what it says in Arizona. I just don't know at this point.
Just talk afterwards. I can
Thank you.
Any other questions? We'll move on to, sure.
It's pretty disheartening today to see how many pharmacy techs, pharmacy reps, students, but we don't see many of our doctors. There's maybe a handful of you guys here today. What can we do to get more of our pain doctors, our neurologists, our family practice doctors to come to these conferences and listen to this?
That's the million-dollar question. I think continued conferences like this are at least a starting point, and at least it gives us a chance to build some momentum for that. But continually not giving up and keep going forward, I think, is the process we need to take. And we do have young doctors we're training right now who are learning this in our residency programs. We're starting to teach doctors here in Montana for Montana. And so those are good places to start for the future of what's happening here in Montana. So I know at least with our residency program, we're trying to teach our family doctors, our future family doctors, about compassionate care and being more comfortable with it. But it is a challenge. There's a lot of stigmatization, prejudice, and I would say stereotyping of patients that need, and really what we need to focus on, we'll go back to it a little bit, need to learn how to build relationships with patients and build that trusting environment. Without that, you can't have anything as far as starting any type of treatment plan. So. But yeah, we're trying.
This question is for the patient representative, or maybe some of your peers who have all touched on frustration with going to the pharmacy and being denied having your prescription filled. So I'm curious, as I start my practice in pharmacy, if you came into the pharmacy, or this gentleman came into the pharmacy with your prescription that might have a very surprising high dose, and I haven't met you and you haven't met me, we don't know each other, I'm wondering what suggestions you have to me. What questions should I ask you to make sure that this prescription is safe for you?
I think, the first thing is when you go into pharmacy, sometimes they just, they look down on you. I've got to the point where I would carry my back file every time I went to the pharmacy, which is about that thick. I've had over 29 injections, the back surgeries, all of it. But, you just, there's an instant, as soon as you show you have a script for opioids, there's this immediately looking down at you like you're an addict. It's just automatic. and it even happened when I was going to the same pharmacy for years, and they'd seen me through all 4 of my back surgeries. They knew my history, and yet they would still started treating me like I was an addict. I've been grilled, well, why do you need opioids? Where, you know, it's not private. You're just standing at the counter. You have a room full of people sitting behind you, and you're having to explain why you need pain pills. And I'm like, I mean, I've literally turned around and just pulled my shirt up so they can see the scars on my back. This fall, I had a breast reduction to try and help with my pain. I also had to have shoulder arthritis removed because of the Ehlers-Danlos, the hypermobility. So again, that also looked like, so there was 3 different doctors giving me pain meds. Well, I had surgeries, but again, it was automatically, with not even asking, it was just automatically assumed I was doctor shopping and pharmacy shopping, and you know, I went to, I'm not going to name the pharmacy, but on Christmas Eve, had my script turned down, and so went through withdrawals on Christmas. So you know, it's such a difficult thing, you know, and I know we're struggling because the pharmacies being limited on how much they can carry, you know, and so they do send you, say, well, Walgreens across the street, they still have some. And I think that now that we have the prescription drug registry, it shouldn't really matter what friggin' pharmacy I go to. Like you, if I'm going to go to Target to get other stuff, I should be able to get my script filled there while I'm shopping. If I'm going to be going to the grocery store, I'm going to fill it at Safeway. Everybody can see on the registry what you're taking, how often you're getting it. Why does it matter where I'm getting it filled then? You know, it's just, but I think it's the attitude that, you know, and like I said, that we're just, as soon as you say you take opioids, you're just automatically viewed as an addict. It's just boom. And so, I don't know if that answered your question, but I guess I'd go back to my original is believe first before you want to start judging. And my experience is you get judged first and then maybe they believe you.
And I'm going to switch over to Jennifer. I know that she wanted to make a comment here.
No, I want to ask a question, which, and maybe you know the answer to this, but how long does it take in the state for a prescription to get uploaded to the prescription monitoring program? Because in some states it can take, what? It's not required. You see, in some states it can take weeks for that to happen, and so it's not like you can go to a pharmacy and assume that next week it'll be on. Anybody can check the program. So do you know what, and the other thing is in the different states that online program is financed very differently, and in some states it's very underfunded, which is why everything takes forever. You're saying it's not required for pharmacies to upload to the? It's not, I mean, that's, so in other words, that's to answer your question, Tootie, because the thing is, if it's not required.
It is required.
It is required. Well, I was surprised because it should be required in every state that has this program, but sometimes it takes quite a long time, so you can't assume that it's going to be immediately uploaded so that any pharmacy could check on it next week or next month. Anybody know?
Well, I just wanted to comment one thing.
Okay, if it's
Yeah,
1
it
week,
is
then
1
that's,
week.
okay, then that's a short time.
So one thing on what you said, I saw a letter, a pharmacist showed me a letter from one of the Montana Board of Pharmacy heads, and it was saying we have to, basically the tone was, we have to control opiate prescriptions. We have to control the number that are out there. And the pharmacist was actually feeling pressure and feeling intimidated about giving out opiate prescriptions from this letter from the Montana Board of Pharmacy. So that's part of the problem too when you present a big one. Now if you're on record there, they can pull you up and see if that's the usual prescription. That shouldn't be a problem. But if it's a new prescription or from another doctor, yeah, some of the reticence is coming from the top down.
I wanted to just make a follow-up comment on what Tootie said, and I think it is less important. It's still important to have one prescriber and go to a consistent pharmacy as much as possible, but you're right. I think it's a little bit less of an issue than it used to be because that was the only way that we could track things. The one benefit, if you do continue, well, there's a few benefits from my perspective. If you go to the same pharmacy, we have the drug interaction screening system. So if we have all of your medications at one pharmacy, then we can do a full drug screen. But if you have some medications at one pharmacy and some at another, then that's a safety catch point that's being, that we can't do in the same way. Also, hopefully, having a relationship with a consistent pharmacy and a consistent pharmacist could be beneficial to you, but I know that's not always the case. I think you're absolutely right. I do hear this a lot, that pharmacists can come across judgmental, and that's not the right way to be at all.
That doesn't build a trusting relationship, and I keep limiting, okay, I'm not going to go to that pharmacy anymore. So then I started going to a locally owned, and they treated me like shit. It's like, oh, won't go there, and so I just keep, I believe in putting my money where my mouth is, and if I'm being treated poorly, I'm not going to spend my money at a store.
Don't blame you.
I'm going to direct, one of the things that Tootie had mentioned, wanted me to come back to Brandy, and that was regard to medication safety, safety protocols, and keeping pain patients from being victims of crime, because it's publicly known that they're actually on opioids. And I would just find it, if a pharmacist is talking with you, Tootie, about your opiates, there are actually bad enough people out there that are actually just seeing who's getting a prescription for an opiate and then maybe a victim of that. And then, there's also people that are patrolling the internet, or not patrolling, but just scrolling through the internet looking for possible victims. And so I'm going to let Brandy speak a little bit to medication safety and how to keep yourself safe and your medication safe and family safe.
I keep mine locked up in the filing cabinet, except for my daily dose.
Yeah.
The bottles in the filing cabinet.
Can I high five you?
Huh?
Can I high five you? Yeah, thank you. The Prescription Drug Task Force was formed out of just community safety, which, again, I've never found anybody that doesn't have the same idea of what we want. And how that looks in your own family and in your own life can be very different. We get that. The reality is that our medications, though, are being either accidentally ingested by our children or maybe first-time experimental. I work with a young man that he took his parents' pain meds once, just had a bad day, and he's now an addict for the rest of his life. And so we know that they can be helpful, and that's our only purpose, and the only reason we do public education is to keep everybody safe. I left our task force meeting last week, and one of our members knew that this was happening, and she was going to try to attend, but she said I could share this. Her partner suffers from chronic pain, and she was really just complimenting us on some of the things that Dr. Mentel has done and our awareness campaign. And she said, people need to understand that not only try to keep your medications safe, but when you are on medications, keep yourself safe. We know at the university that students that have stimulants are very high targets. They are followed, their dorm rooms are broken into. And so she was telling us that her partner often has fentanyl patches, and I've never worn one, but I guess you can hear them. And people follow him to his car in the evening after dinner or at a doctor's appointment to offer to buy them. So when we're talking about safety, we're talking not just about, that them being on the streets, but also keeping ourselves safe. In Missoula, it's the second reason your home will be broken into, or somebody that you know will be in your home looking to steal. Does anybody know what the first reason is your home might be broken into? What do we love almost more than we love medication in the state? Our firearms. So that's the thing about medication safety, is that it really benefits all of us. The poisonings that are going on, it's the second leading cause of accidental death for our children in the state is accidental poisoning, and 90% of those are medications. And it's not just narcotics by any stretch of the imagination. I know when we started this program, being a mom, it's kind of a pain in the neck to lock up your meds. My daughter's on medication that is required twice a day, and it was an adjustment. We also, and I appreciate so much what you're saying, sir, about suicide. We now are partnering, I love the state when we're upstream, we're partnering with the suicide task force because we know that the two largest means of attempts are firearms and prescription drugs. Unfortunately, firearms obviously have a higher completion rate, not unfortunately, but firearms have a higher completion rate. So we're joining together because really firearms are not much different than prescription drugs. We think people should have them if they want them or need them, but if you use them properly, store them properly, we're pretty safe. And most people that have either medication or firearms would not want them to be stolen and be used improperly, and definitely wouldn't want to be a target, and also would be bone crushing if a family member misused them. One thing that we are talking about and trying to pass along about easy means is, and I'll ask you all, does anybody know how long a teenager, so 18 and under, takes from the time they think about committing suicide to the time they complete it? Does anybody know how long they take? Who just said that? Yeah, it's 10 minutes. 10 minutes. So what if you're going to take 10 minutes to think about something, what are you going to look for? Whatever's there. And absolutely, if it's something, whether it's your firearms or medications, whatever you want to have in your home, we support that. We want people to have that freedom. But it's hard because they're going to reach for whatever they're going to find first. That's one of the reasons, too, that we talk so much about locking them up. It's inconvenient. I'm really impressed that you do that because it's inconvenient. We also talk about maybe just putting them up and away. I know a lot of people, your medicine cabinets are not really cabinets anymore. We've learned that the hard way, trying to have displays. But, underneath your bathroom sink, or if it's convenient to keep them on your kitchen counter. We get it. But when you look at young kids, and also that medicine looks like candy. I don't know if you've probably all noticed that it looks like candy. They try to make it taste well. And I think that's another increase in the poisoning. One thing, when Safe Kids and I were working together to just sort of think about our talking points, in 2 decades, preventable injuries have just gone down and down and down and down. But from 2000 to 2009, drug poisonings in 19 and under has skyrocketed. And 90% of the injury deaths of those kids is from medication. And so it's so fascinating to just think about how something can be so helpful and also in the wrong hands, even if you don't mean to, can be so dangerous. And that's why I love the opportunity to have a conversation, because I think for the most part that we're all on the same page with that. That's pretty easy. And as our colleague pointed out, also just if you already are going through this type of pain and this, and not being treated well and all of these things, and then someone is, stalking you to your car or breaking into your home. One thing I hear about college students, all of a sudden they have more friends than they've ever imagined when they break their leg, or when they find out they're on stimulants. So that's really just kind of what's behind our thought, is just how can we keep everyone the most safe as possible. And it is, I know one thing that we talk a lot with little kids, it's pretty preventable. And so it may be inconvenient, and that's why I'm very impressed. It may be inconvenient, but locking them up and storing them away, and then also disposing of them properly. I know we like to hang on to things, but we really just need to look at what we have in our homes, and do we really need that item anymore? So I hope that was a little bit of what you're hoping for. Okay.
Right on target.
Want to please you? Dr. Mentel, we have a question over here.
Great.
Hi, my name's Felicia. I'm a family medicine resident, and so my question's a little bit off tangent from what we were talking about here, but I'm just, starting to be a provider and prescribe, and certainly in family practice, primary care, encounter a lot of chronic pain patients. And, kind of referenced earlier, the goal of chronic pain treatment should be more focused on functionality and what you want to be able to do rather than the pain itself. And one of the more difficult encounters I get is a previously very healthy, active person. Maybe they had broken bones, aches and pains here and there, and the pain, quote, went away at some point after treatment. But for whatever reason, they're kind of crossing the threshold into chronic pain, and I try to talk to them about their goals of care, and they said, I just don't want any more pain. And so I wanted to hear, from a patient perspective, what are maybe some helpful things that you have heard to help kind of shift the thinking away from getting rid of the pain to achieving some sort of functionality, and maybe from a provider perspective, what approaches have you found helpful, and maybe the opposite from both points of view. What have you heard or tried that have not been helpful, or you wish your doctor didn't say to you?
sounds like a question for Tootie, and then a follow-up with Dr. Schneider, so.
Well, I have to say, well, first off, I'm a Scorpio, and so we either do or don't. We don't, middle ground is just, it's not in the vocabulary. And it's something that I struggle with continuously, and my PT and my doctor are always yelling at me to pace myself. But on the other hand, keeping busy for me is one way to distract myself from the pain. If I'm busy and in the flow, I'm not thinking how much I hurt. If I'm laying on the couch on an ice pack, guess what I'm thinking about? How much I friggin' hurt. So for me, keeping busy is one of the tools I use in the toolbox. But for me, I know that pain's never gonna go away completely. I get that, and it's probably the rest of my life, and that's just what I have to deal with. But it is about what is it I want to be able to accomplish. I'm single, I live alone, I have animals, I've always been active. In fact, most of my doctors say I'm more active than most of their patients. And I want to stay that way, because to me, living is doing what I enjoy doing in quality of life. And so I think it's having that conversation. What does quality of life mean to them? What is the things that they want to be able to accomplish? Do they want to be able to go to a movie once a week with friends, and what's it going to take to be able to do that? Do they want to be able to go hiking? So I think it's like Mark was saying, and that's why family doctors do need to be the ones doing it, because you do build a relationship. You get to know your patients, you get to know what it is they like to do, what makes them feel fulfilled. And so instead of looking at how do I take it from a 10 to a 7, I mean, I always hate, it's like, I don't know what it is. It's like, I never say 10 because I know it can always be worse. So I think putting the focus more on what is it that you want to do to have a balanced life so that you can feel like you have some quality, and kind of approach it from that direction.
I guess I have a little bit of the patient perspective too on this one. So I had my back injury at 30, and I was really an active person before that happened. I played soccer like 3 and 4 nights a week on different league teams. I was really physically active, and after my back surgery, I was unable to run, and I haven't ever been able to run again. And I lost a lot of my identity at that time, and so I think sometimes we think that patients should just deal with it and just get on with it, but it was a very long process for me to kind of realize who I was going to be, realize what kind of function I had lost and what I had left, making sure I never got back to the place I had been before, and taking better care of myself. But I had to learn to pace myself too, like Tootie did, and I did not do that well. Now I act a lot different, and I don't want to hurt myself. But it's not something that just happens, and it's a long process for people.
Well, I really want to second what you said, Tootie. I think that the first thing is that patients need education. And typically when a patient who has chronic pain comes to see a doctor, their goal is to get rid of the pain. And they need to be educated. So I would explain to a patient that if you are able to reduce the pain by 50%, like they come in with pain that's 10 out of 10, and then if you can get it with whatever modalities you're using to 5 out of 10, you can publish that if this is due to some new treatment that you found or whatever. That's considered an excellent result. And so you have to be realistic. I mean, a lot of times I think that patients are unhappy because they come in with these unrealistic expectations that the pain is going to vanish, and so they need to be educated that that is not the way it works with pain, that a realistic goal is to get a maximum of 50% pain relief. And the idea is to get the pain down to where it doesn't take over your brain to where you can't think of anything else. I believe that distraction, as you were saying, is the first line of defense against pain. So, I know that from personal experience. I've got a lot of back pain stuff. So you can see that there's a seat up there behind the desk. I had asked Dr. Mentel to provide me with that seat because normally I can't stand for more than 5 minutes without getting back pain. So I gave a 30-minute presentation this morning, and I stood up the whole time. And this has happened to me before. Normally 5 minutes is the maximum, but what I have found is if I am very involved with some activity, like if I'm giving a talk, I'm really focused on giving the talk, I was able to stand for the entire 30 minutes, which I told you I didn't think I'd be able to do. So, and it isn't the first time this has happened.
I was ready to catch you if you needed to.
Yeah, so, by this afternoon, I mean, I had a whole day of it, so I was actually sitting in that chair for the entire hour that I gave my afternoon talk. But the point is, distraction is, again, it really, that's what, cognitive behavioral therapy is all about, kind of rethinking the things that you say to yourself and the way that you say to yourself. And, a patient like you described might really benefit by that. What are you telling yourself about your pain? What are you telling yourself about your goals? If they can get some help in saying different things to themselves and in realizing that they have different expectations, the goal is to get the pain down to where you can be distracted, where it's not that bad that it's impossible to get distracted. And so I think that what you're experiencing as a new doctor is very common when you see a pain patient. And education. This is why the relationship between a doctor and patient with chronic pain is so important, because they have to trust you and you have to be willing to sit down and talk to them about these things.
I'll just dovetail on that a little bit. It's sitting down, I'm just thinking of a patient who I had, and this is before I become more educated and have been working on becoming a better doctor at helping my patients who are suffering from pain. But one of the patients I had, he said his pain was 9/9, had him on opiates, and he said whenever he took it, his pain never went away. It was always 9/9. I started weaning him down. I figured it was a failure, so we need to move him away. But then I started asking him functional questions. He said, I can't weed the garden anymore. I'm not able to play with my grandkids anymore. I'm not able to do all these other components to my life. And I said, whoa, I just missed the boat. Let's get you back started. And we got him back to his medicine. Even though he comes in and says each time his pain is no different with the medicines, his function has changed with those. So to me, I have continued him on the medicines because he's a much more functional individual with that. And so really the goal is kind of try to steer them away. So we don't even talk about pain when he comes in because the pain score is always the same, but I talk, how is your functioning now, and what kind of goals do you want to get to, and are we getting there, and am I seeing any side effects or any worrisome things that make me concerned? I know for the conference here, we're talking about an ethical approach, and an ethical approach to medicine, but it's an approach that you can have with pain where you can say, I kind of go a stepwise down as I'm seeing my patient. Is everything I'm doing for this patient helping? Is their function better? I do a little checklist in my head. Then I do, am I harming the patient? And so I go through a little checklist to look for side effects, do a prescription drug registry check, and then I go through a little checklist with making sure the UDSs are congruent. And then I talk about, autonomy. Am I having him involved in his care? I feel that these individuals need to be, it's almost an ownership of their disease, and they learn how to manage it. It's kind of with your diabetics who, the best diabetics are ones who learn how to manage their disease the best, and they take ownership of it and don't take a passive role. So I always encourage them to be active and be an active participant and keep us informed, and then just make sure I create a nurturing environment for them to kind of feel free to talk about them and not be prejudicial or stereotype. I don't know if that helped you much, but hopefully that helped a little bit. So, question?
One thing we started out talking about was that chronic pain patients truly suffer from what somebody said is a conflation of pain patients with addicts. And I think what we haven't talked about is the fact that some people become addicts. And a lot of times when you hear interviews or you hear news reports, people will, it's some, soccer mom or business person who says, they didn't go to the doctor seeking medicine. They went for an acute problem, or maybe they had a surgery or something and they started taking medicines and they got refills. And next thing you know, they're robbing pharmacies and using heroin. And I assume that some of these reports are true. And what we're talking about, this crisis we're talking about, is about them. It's not about you, but you're the one that's suffering from that, and you're suffering from that. And you hear from doctors that they don't want to prescribe because they don't know. They don't know which one you are. And a lot of times, it's the prescribing in the first place that got them into trouble. And I guess my question, I kind of have two parts to the question. One is, how do these people get lost? I mean, if you're giving somebody for acute pain or maybe a
a legitimate problem, how do they become addicts and then get abandoned? How do they end up without the physician who initially was prescribing saying, whoa, we got to pull back on this and figure out how to address this other problem? And the other thing is, how does a doctor, when a patient comes in, know that this is a person who's trying to scam them? Because they get scammed. They get scammed all the time, and it just makes them want to quit prescribing altogether. They just don't want to deal with it because they know they've been tricked, they know they've been lied to, and they feel like they don't know how to, they can't deal with it. And so that's a real problem, and we can talk about the importance of treating chronic pain, but there really is a problem also.
Well, as far as chronic pain patients becoming addicts, at least the research I've read, it's a very minute, like 5% of us actually will become addicted. Physically dependent, yeah, but actually addicted, no. I mean, some of the things that I've heard is like, somebody goes in for a broken leg and they're given, a huge dosage of oxycodone. And so, yeah, again, it's education of doctors. How much do you really need for an acute incident of pain? Do you need to keep refilling it? I mean, I think there's something like that. And I guess, and yeah, you're going to get scammed. I mean, it's kind of like when people get mad over, folks who cheat on welfare. Get over it. People cheat on their taxes, corporate cheats. It's just going to happen. And I think as doctors, you have to, yeah, you're going to get scammed sometimes, but if you do the due diligence, you really talk to them, you do the screens, you get to know them, you might get scammed a couple times, but you're going to figure it out that they're not legit. But I don't know.
Well, you're super smart. I was kind of going to say that. She says it better, but I'm really glad that you brought it up because it is true that, they're all correct, obviously, that it is about addiction at the end of the day. And majority of the people that we work with and that we talk to are the soccer moms or the football player or the varsity soccer player that, yeah, breaks their leg or does something that's painful, but by all means is not chronic pain. But they've left with an enormous amount of narcotics with zero education. They hear this all the time. I love doctors. I love pharmacists. I've been blessed in this community with amazing care. But it's not uncommon that people are left with these medications, and there's so much worry about how they interact with the body, which should be there, but very little education about the safety and the addictive qualities. Because as we know, addiction is brain chemistry and genetic. And so those are things that are, when you go in and have a broken leg, aren't being discussed. And that is who we talk to the most. And people, like you said, it is the soccer moms. And so I'm glad that you brought it up because it isn't the chronic pain patients. And it's one thing that we've been, and I know Dr. Mentel, when I met him, he was working so hard on this, but just our emergency rooms prescribing less. So when you come in on a Saturday with a broken toe, I think you also have all said it really well that we're trying to educate the public about absolutely not what you guys are dealing with, not chronic pain, but pain sometimes happens. And what does that look like to try to fix it? And most people are pressuring doctors for it to be fixed right away. And again, it might be a broken toe or something really simple. And so that's what we're struggling with is how do you deal with the addiction side of something that is very addictive and educating people about that. The last thing with that, again, with the suicide prevention, as people talking in the suicide world, you have to talk about firearms. And it's always interesting to me because most people don't understand that firearms come with they all come with locks, and they all come with very rigid safety information about home safety and kids. And medicine doesn't. And so I think that's what we're trying to figure out is the balance and trying, and I appreciate so much hearing the stories, trying to figure out how can we get the public more educated about that so they can talk more to their doctors if their kid is injured or if they're injured themselves. Because you're right, we are seeing a huge incline of your average person having one injury and they are going to heroin. Those stories are very true, very true.
I know I'm supposed to moderate, but I actually ended up being more like a panelist. I'm thinking, yes, not just the law is ownership. I'm thinking to that question, and there were so many thoughts that struck my mind when you stated that, and I think one of the key things is education. There's a key component that because these medications are prescribed by a doctor, they must be safe. And so there's a lot of pill sharing that occurs once I write a prescription for an opiate. It's not uncommon for, the doctor prescribed this for my headache, you're having a headache, here, you take one. If I had $1 for every time I heard that story, or I'd be like, I wouldn't be here. One of the other things I'm thinking about is how do people get lost in the system? I think there's some improvements in that with at least a prescription drug registry program such as that. It's not as easy to get lost. It's easy to see. It still can happen. And if someone really tries hard, they can try really hard and they can kind of keep themselves hidden in the system by little tweaks of name changes, little, moving to different states, moving around. So there are those possibilities, but they're trying really hard, and so that's not the typical patient. But those things are getting improved upon, but there's also patients getting lost just because doctors aren't paying as much attention because of the other duties and clinic duties. And I don't want to get on another soapbox, but the business model of medicine is one, more productivity, see more patients. You don't have time to make that connection. And it's those, and I'm going to go to an old song and dance. It's a relationship with the patient that you can build over time, that you need time to do that. And, 15-minute appointments, productivity-based, all the money revenue generated for any hospital system or physician practice has to go through the physician. There's no one else who can bill for those services, no one else who can do charges, so money comes in and keeps the flow going. And so it's a conundrum with that model that if I could dismantle it, I would, but I don't know what I would remantle on top of it. So I hope that helps somewhat.
Can I just add to that too? Sorry, just because it's with this. Isn't it also fear? I wouldn't disagree. It's education of several, the primary care provider, the pharmacist, but it's also education, I think, of the regulators and also of law enforcement, that these are colliding public health crises that even though we don't think that they're impacting one another, they are. And I was really disappointed that law enforcement wasn't in the room tonight. And it was, the reason brought to me was that they didn't want to be a part of the controversy around opioids. And we've got to figure out how we can get everybody in the room to have the conversation. How do we do that? How do we get law enforcement here? Brandy, I know you're here representing the task force, but we need law enforcement in the room. And regulators of our docs and our pharmacists and so on.
Can I just address that respectfully? That's not why law enforcement isn't here. Law enforcement in this town, I can't speak for the rest of the town, and I know how much you work with them, could not be more involved. And the prescription drug diversion cop it's such a huge problem. We have one detective, that's all he does. In my opinion, and professional opinion, could not be one of the more compassionate men I've ever met. I work a lot with some of the people he's arrested, and they all say that he's saved their lives. I can't speak for them, but one of the reasons that law enforcement wasn't here is because law enforcement feels very strongly that although there is a connection, absolutely, that they are not experts on pain management. And so when this became a discussion about pain management, it was a decision that that is not their expertise. When you're talking about safety and diversion and ways to blend these issues together, absolutely. So in Missoula, the collaboration, I've never seen it stronger. I know you probably could speak to around the state. But so they are here, and I also am tasked with some of my colleagues to bring back the stories. But I guess that's just important for the work that we've experienced in Missoula, that law enforcement could not be more caring and trying to figure out the balance, because there is also a problem with diversion. and trying to figure out that balance. I think that's what we're all saying, is how do you figure out that balance? And one thing that I appreciate tonight that I feel so blessed to bring back to the task force is that's what we're all saying. We might come from it differently, but it is the balance that we want to find.
I was just thinking that, in my mind, I think of it as a three-ring circus that we actually have going on right now. We have pain patients who need pain control. We have addiction over on one side, then we have misuse and abuse and crime up on the other, and it's this delicate dance that everything is involved with, and you can't affect one circle without affecting each other. So it's one of those arenas that you just have to be aware of, and we all have to be cognizant of. It's an entire story. It's not just one issue. And I will echo with what Brandy said. I know the local detective, and he's probably more active than anyone I know of. I've had conversations with them, and they felt very torn about being here tonight, but they didn't want to derail the conversation from pain and pain sufferers, and they thought their presence might cause that to happen. So they wanted to make sure pain patients had adequate representation here. So, and they were torn. But I've also been tasked with the idea of bringing forth the idea that they are very involved in at least in the Missoula community. I know that. So, but I think having some forum in the future where we can have law enforcement together and start building those bridges and getting all these together, I think is important. I mean, we also had at the conference today, not a lot of us knew, but the Attorney General, Tim Fox, was here. We actually have his representative here today as well. I'm going to point out.
She'd like
Kerry.
to say a couple
good.
words too.
Yeah,
I just
so
wanted, I'm going to give her the mic, but I just wanted to do a time check. Okay. So many of us have been here for a full day, and I know many of the panel members have been here a full day. So just want to say I'd like to get the mic over there and then give consideration to wrapping our panel up for tonight.
I would agree. I just looked at the clock too, so.
So this actually was, I wanted to comment back on what Tootie and Brandy were saying at first about sort of like the idea that there's like addicts and that there's chronic pain patients. And then also, Dr. Mentel, you touched on it too when you were talking sort of about the way I visualized it was like, you know, like a circle split into thirds. Mm-hmm. So I know that Dr. Schneider, you talked a lot about how you think in the media that this gets portrayed as being chronic pain patients. I think that it gets portrayed as being very black and white as well, but I almost look at it as I almost feel that it's the opposite, and that it's looked at as being like only people who are addicts overdose on these substances. And I think that that's a huge misconception. I think it's important to acknowledge that there is a Venn diagram going on here, and there is a portion of overlap. And the other thing is that being addicted to a substance does not make anybody a bad person or an immoral person. We know that these are very strong substances, and we know that we have pathways in our brains that in some people light up a lot brighter when they get these substances into their bodies. So I guess like what I'm trying to say is I think that saying, well, there are chronic pain patients and then there are addicts is simplifying it too much. Because unlike what you both were saying that you've seen sort of anecdotally, we all have heard the stories about, well, I had an acute pain episode that I got prescribed medication for, and then that led to me becoming addicted. But I believe the data tells us, correct me if I'm wrong, but I think that this is what a lot of the CDC guidelines is based off of, is the available data tells us that the longer that someone is on these drugs, the more likely it is for addiction to set in. And also, higher dosages lead to higher chances for addiction.
Let Dr. Schneider handle that one.
I can't comment on the specific studies that you're talking about. I think there is a lot of overlap, and I didn't mean to say that you never have someone who has vulnerabilities from their childhood trauma and so forth, or genetic tendencies who is then exposed to opioids because of some injury, who then doesn't at that point have this like a very super positive response and becomes addicted. I'm not saying that doesn't happen, because it does. I'm saying that I think that the chances of that happening are overrated, that it's a small percent. It's a percent of people who had prior vulnerabilities. In the same way that, you know, the back, this is probably before your time, but a lot of people returned from Vietnam, soldiers who had been using opioids, I guess as a way of tuning out over what was happening to them there. And there was an expectation that there would be a huge amount of drug-addicted soldiers in the U.S., and that a lot of them actually, when they got back to their usual environment, were fine. And that what they found was that the people that became, who actually had a serious addiction problem when they returned to the U.S. were often ones who had had prior PTSD, childhood trauma, things like that, and were more vulnerable when they were exposed to these drugs to then continue with a serious addiction problem. So there's overlap, but it's not as black and white as saying that this never happens or it always happens when they're exposed to drugs. That's all that I was saying.
I just wanted to kind of end, I don't know if I'm ending it or not, but, but I was just going to say, I want to say, first of all, thank you for doing this. And you've talked a lot about education, which is very important. I just want to talk on the population base, which you're doing right here, is the dialogue. That most of the people in all of this, on all sides of it, really want to do what they think is right. And it's a matter of having these conversations, and I think this has really made a big difference. So I want to thank the people that put this together.
Thank you. I think we had one more comment. Did you have?
Two last comments.
I've had a thought while we're sitting here, and it's some about the terminology that we're using, and I don't know how you're feeling, but I'm a little uncomfortable calling people in the room patients, chronic pain patients, and also addicts. And I'm thinking that maybe as a group, we should start thinking about different terminology to reduce stigma and bias, and maybe saying people with chronic pain or people with addiction issues. I don't like some of the connotation that those words are resonating, I guess, with me. So it's a challenge I might put out there.
Can I comment on that? I just want to say I have a very strong opinion about that as well. As I was part of that group this afternoon that had the patients in it. And the very first one, he introduced himself as a chronic pain patient. And my response to him was that in my experience, if people adopt that as their identity and they say, I'm a chronic pain patient, that often goes with it that those are the people that have more difficulty with dealing with their chronic pain and with getting and with having kind of a positive life, and often do have some more behavioral health issues than someone who says they are a patient with chronic pain. So the chronic pain does impact their life, and it causes you to have various limitations in that, like, for example, having to sit when you give a talk and stuff like that, and more serious things, obviously, in a wheelchair and all that. But that does not have to be like an integral part of your identity. So, I mean, I agree with you that if you are, I am a chronic pain patient, it's like that is sort of the core of my identity, and that is something that is associated with psychological difficulties. And that, so yeah, I think that recognizing that you have that identity maybe is the beginning of trying to put it in a different perspective. So, sorry, you were going to say. And
No,
I just...
it's okay. You have the second. I'm good. I'm good, because if she holds up that sign one more time, I think she'll hit us with her head.
Mark, we have one quick announcement.
Okay, one quick announcement.
So I want to invite everybody to, there's a conference hosted by Dr. Forrest Tennant. He's going to be the keynote speaker, and he's a leading authority on intractable pain, and Gary's on his protocol. So it helps to reduce the dosage necessary, and that's going to be in Helena at the Radisson on July 9th and 10th.
Thank you. I'm willing to stay longer. I'm just joking.
I really like the idea that Dr. Haney had brought up, and I'm as guilty as anyone else on saying chronic pain patients, and I really like the thought process of moving to people with a pain condition or something along that line and rephrasing that that's appropriate, I think is a wonderful idea. And one last idea for...
Okay, it's killing me. And I feel so bad because this is my profession, so I can't get it right. But the CDC and the DSM-5, which just came out, has renamed addiction completely. And so, and I feel really bad. Do you know what it is?
The renamed is opiate, they're called opiate use disorders or alcohol use disorders.
Thank you.
It's a use of disorder.
It's a huge victory in our world, but it is a language change, and I just really appreciate that you said that. Thank you for knowing the word.
I thank everyone for staying here till 8:30, and you guys get to be first in line for breakfast tomorrow. So.